All right, so we'll go ahead and get started. I want to be conscious of everyone's time. I know it's lunchtime, so I want to be cautious of everyone's time. So welcome everyone and hello. I'm Maddie Dix. I am the alumni coordinator for the School of Nursing. And welcome to the third session of the School of Nursing's Hub Research Series presentations. As you all probably already are aware, the School of Nursing has an abundance of research programs that are aimed at advancing nursing, science, and practice. And within the school, there are 5 research areas, or hubs as they are called, which provide funding opportunities to foster collaborative and interdisciplinary research programs. They feature faculty members and students with similar research interests pursuing similar projects on topics, themes, or integrating multiple existing projects around one theme. We are excited to continue this research presentation series with the Nursing Health Sciences and Services and Policy Research Hub. Dr. Grant Martsolf is joining us today to present this hub and present the health services and policy research happening within the School of Nursing. This research that studies the finance, organization, and delivery of healthcare services. If you have any questions at all during the presentation, the chat function is down at the bottom, and I will monitor and moderate that at the end of the presentation. We are offering continuing education credits for this session. There is no potential conflict of interest or financial interest by the faculty and or planners of this activity to be disclosed. There's no commercial support provided for this activity. There is no endorsement by the University of Pittsburgh or ANCC of any commercial products discussed / displayed in conjunction with this educational activity. And lastly, the entire session and participant feedback, which will go to you all in an email after the presentation, must be completed in order to earn the contact hours. So without further ado, I will turn it over to Dr. Martsolf to learn more about the Nursing Health Services and Policy Research Hub, which is a mouthful to say. So go ahead, you are all set. Please take it away.
I'll go ahead and share my screen. Let me go ahead maximize. So can everybody go back to the beginning here? Sorry. And can everybody hear me? I usually wear a headset, but I don't. I'm in the office. Is the volume okay?
Yep, you're great, and we can see your screen, so that's perfect.
Okay, great. So I thought maybe it might help. This is kind of a small group. So are we okay if folks ask questions, interject with questions, or do we want to do
whatever you would like? If you want, as people ask the chat questions, I can interject really quickly and ask them, or we can do a Q&A at the end, whatever you would prefer.
Well, if folks have pressing questions about as I go ahead and ask. It looks like a relatively small group. I think that's fine, and then we'll close with hopefully 20 to 30 minutes of Q&A. I'm hoping to go for 30 or 40 minutes of just pure talk. So again, thanks so much for the introduction. I'm excited to talk about this. Just so to give folks some sense, I'm a nurse by training. I have a bachelor's degree in nursing. I practiced for a very, very short period of time, about a year after I graduated from undergraduate. Ended up doing public health for many years, and I worked in hospital consulting. I got a PhD in public policy. Came here to Pittsburgh to work at the RAND Corporation, which is a public policy think tank, and was recruited to the University of Pittsburgh about 4 years ago to help build some of our health services and policy research agenda. So this hub is really central to what I'm doing here at the university, and so I'm excited to see it get off the ground about 8 months ago, and I'm hoping that it'll grow into a formal center where we can have some funds to do some fun things. So I'm excited to talk about it. I'm hoping that this will really launch a real strong health services research and policy agenda. We've hired some faculty who have some interest in this area, and we're hoping to engage other faculty from across the nursing school in these types of questions. So I want to start out with a little background on what we're trying to do within this hub. The first thing I want to say is, as all of us know, the healthcare system is facing major challenges in the 21st century. I think the central paradox that we face as people interested in healthcare is that really well illustrated by this graphic here that shows OECD countries, which are essentially middle to high income countries, in terms of their health spending per capita and life expectancy. And you can see the United States is the major outlier. we spend a tremendous amount of money and get a relatively modest return, at least in terms of life expectancy. So we're trying to solve this problem. And sort of within that paradox, I think there's some major issues that interest people like me, interest a lot of the researchers that are sort of exist in this field. So again, the first one is very high spending. And again, that was already sort of baked into the previous slide, but our healthcare costs are exceptionally high. You can see we spend, at least from this slide in 2014, and it's about the same, a little bit more now, about 16 to 17% of our GDP, so our gross domestic product, our entire economy on healthcare. So at the same time, we've really struggled with providing access to care for everybody in the United States. The primary gatekeeper for healthcare services in the United States is having health insurance. We've always had this persistent uninsurance problem. The only high-income country in the world that has this uninsurance problem. We were able to eliminate some of this uninsurance with the Affordable Care Act or Obamacare, but we still sort of persist with about 10% of the population not having access to health insurance. So at the same time, we're very concerned that we're not going to be able to meet demand for services. Our population is aging, we're getting sicker in terms of, at least in terms of chronic conditions. People aren't sort of dying of fungal or infections and other, tuberculosis and diarrheal diseases. And people are living a long time with chronic conditions. And it creates a tremendous demand on the healthcare system. And we're not quite sure that our current delivery system can manage demand. This is just an example of the shortfall in primary care physicians over the next 15 years or so. So the performance of our system is very mixed. We seem to have decent access to care. You can see, obviously it's too much to really summarize this entire table, but sort of the top set of rows compares our healthcare system to other healthcare systems in terms of access to care, and then patient perceptions of care, our ability to provide preventative care, and then like various clinical outcomes. And ultimately, we seem to have pretty decent access to care for people that can get it. And once you're in the system, we do relatively well. We tend to really reduce 30-day mortality for stroke and AMI, et cetera, et cetera. But many hospitalizations could be avoided through better ambulatory care. So our care system, in terms of quality, is very mixed. But we have a major equity problem. I'm not quite sure how this horizontal inequity index is measured, but it's sort of a composite measure of different metrics that would assess the equality or equity within the healthcare system, and we rank the worst by a big magnitude. So these are the sort of questions that we're interested in addressing in the field. So health services research and evaluation, or health services and policy research, depending on where you're coming from, but we'll just call it health services research for our purposes here. You can see this from a number of different slide decks. So this is a multidisciplinary field of investigation that studies how social factors, financing system, organizational structures and processes, health technologies, personal behaviors affect access to healthcare, quality and costs of the healthcare, and ultimately our health and well-being. So those are the sort of outcomes of the care that we deliver. And I often show this little schematic to help people understand the kind of questions that we're interested in answering. So we're really interested in all of the yellow arrows. We're interested in understanding how the financing system might impact health system structures. So how does the healthcare system impact the types of technologies that hospitals adopt? How does finance impact the processes of care? So what we do with our technologies, and how do those technologies impact access, cost, quality, and ultimately well-being? So any of these arrows that you're looking at are the sort of things we're interested in. And an important distinction for health services and policy research is, again, we're very interested in public policy, so what governments can do to affect this ecosystem, but also particularly interested in, not in a particular disease category, although a lot of us do have particular interest. We're interested in finance and delivery of healthcare, and ultimately on patient outcomes. So, at least I like to think that well-constructed health services and policy research is necessary to ensure access to high-quality, affordable healthcare. I think that's sort of in the best-case scenario. We do things like testing existing delivery models, developing new payment and delivery models, workforce planning. So how do we know how many registered nurses we need? A lot of the work that we do. Quality improvement, identifying and evaluating health policy interventions by state, local, and federal government. And for folks that are nursing faculty on this call, you know that we had a webinar with our dean yesterday that was outlining how you might get inducted into the American Academy of Nursing. And that is heavily dependent on your impact on public policy. And historically, nurses have actually been underrepresented in the field of health services and policy research. A lot of our historic work is focused on clinical practice, developing, testing, refining interventions aimed at improving symptom management and patient outcomes. But this field is growing, nursing, health service, and policy research. Approximately 20 years or so ago, we developed a group called the Interdisciplinary Research Group on Nursing Issues, which is an interest group within Academy Health, which is the premier health policy professional association. We're now the largest and most active interest group in the Academy. I was a part of organizing a large meeting in Bozeman, Montana, that put together a strategic plan for the questions that we need to answer as nursing, health services, and policy researchers over the next 20 years, 10 to 20 years, in order to really help improve the healthcare system. It was very well attended. We had experts both from nursing, outside of nursing, and really pushing our profile within health service and policy research. But with that being said, we are very, very focused on the healthcare system. But part of what I'm trying to do, and what I think we need to do, and the field is beginning to recognize, is that we really need to move beyond classic measures of health in terms of life expectancy and mortality, and move beyond just thinking about how does the healthcare system impact health and well-being, and to think about broader social factors. The Robert Johnson Foundation Culture of Health Initiative has been very important here, trying to push the role of social determinants of health and to think about health very broadly. So there's all these issues in the United States that very deeply affect our health and well-being that in many ways are outside of the impact of the healthcare system. Obviously, the healthcare system has some relevance here. We think about the high rates of gun violence, the opioid epidemic, income inequality, which is exceptionally important for health and well-being. I think also of the rapid growths in depression and suicide amongst our young. There's all these questions that are really within healthcare, but really are broader social phenomena. When you think about significant social upheaval that really impacts our well-being as broadly conceived. So these are kind of some of the issues that we're particularly interested in within our hub. And we're really interested in advancing the nursing field's ability to interact with and address some of these really important questions. So what are we trying to do in the hub? So in the long term, we're very interested in establishing Pitt Nursing as an epicenter of nursing health services research, drawing really good talent, answering really important questions, and really being seen as sort of a leader in the field. Again, we're interested in extending and supporting the work of researchers currently doing HSPR work within the School of Nursing, but also developing new HSPR capabilities. So drawing in new faculty that are interested in this kind of work. Folks that maybe were doing clinical research but want to extend their work into policy relevance, and also getting data sets, all the things that we need in order to be a really premier epicenter of health services research. So we do have we're trying to be very broad and be a big tent. We do have some focuses. We're interested in examining the impact of health systems delivery models, especially nurse-delivered models on chronic condition care. We're interested in new models of nurse-delivered healthcare, and then we're interested in sort of the overlap of health policy and human flourishing, which I'll talk about a little bit later. So what do we do? If you're interested in joining our work or interested in learning more, we essentially have three things that we do. One is we have a set of research cores, which create places where people with similar interests can come together to answer questions. We have a bi-weekly research symposium that's very well attended. We had one this morning, as a matter of fact, from a friend of mine at Ohio State University. And we fund a number of pilot projects. We have $20,000 or so per year where we can fund original research that hopefully will then set the stage for big funding. So I want to take a few minutes to talk about our research cores. So I really do think that's really the epicenter of our work, where we get research products out, think creatively and intellectually about the work that we're doing together. So these research cores, again, I mentioned this a little bit, but I'll just reiterate. they really provide a context in which researchers with similar interests can collaborate on research projects, again, through shared research experience and resources, and a way to really disseminate key research in the field. So we try to bring, again, research expertise. So we have a number of junior faculty, graduate students, undergraduates, paired up with senior faculty who have some experience publishing in these fields. And we also try to share resources. So a number of us have employed URMP students, which is the undergraduate research and mentorship program. And then we sort of share those resources within the hubs or within the research cores. Because often we maybe don't have enough work for each undergraduate. So we sort of share all those resources, both undergraduate, graduate students. We also share data as well. So we currently have 3 cores. We're interested in expanding these research cores. One is we focus on nurse practitioners in primary care. So there's a number of issues that we study in this space, and I'll talk more specifically about each one of these cores if you're see if maybe you're potentially interested. The second one is behavioral health services, and the third is nurse practitioners in specialty care, or specialty practice as opposed to primary care. So you can see we have a relatively heavy focus on nurse practitioners, and that's largely generated by the interest that I brought here, as well as some of the interests of junior faculty members that have been coming on at the nursing school. And then each of these cores tend to have bi-monthly research meetings, so twice per month. So I'll just talk a little bit about each one of these cores, maybe pique your interest in some of the work that we do. So first is the nurse practitioner in primary care. I'm the lead of that core. And this really serves actually as a project meeting for 3 separate R01s that I have funded with some colleagues at Columbia University. I think that we're very productive. I think that these meetings create a context that really help push papers forward, grants, etc. So, we have probably the last 8 months, we've published 7 papers, at least have them under review, a number of presentations. We have 3 funded grant projects, and then 1 grant under review currently that looks like it'll also get funded. So it's been a really productive teamwork. We also have researchers from other institutions within this core, from Columbia, from the RAND Corporation, which is, again, my former employer. So again, there's 3 grants that sit underneath this research core. One is primary care teams in social network analysis. Very interested in teamwork. So how do nurse practitioners and physicians and MAs and RNs work together in a team? And we're using network analysis, which is, I'm the primary care expert. I'm not the network analysis expert, which is a way to understand how people work together, they interact with each other in order to produce sort of cohesive teams. That's funded by the Agency for Healthcare Research and Quality. We're also looking at nurse practitioner work environment and disparities in chronic disease care. So work environment, again, is the extent to which nurse practitioners feel a part of the team. They have good relationships with physicians. They're allowed to practice at the top of their license and certification, and their interactions with administration. So sort of practice environment, which that construct is really something that health services researchers focus on quite a bit. And we also have another R1 that nurse practitioner work environment and disparities in dementia care. And then the last one that hopefully will be funded soon is really focused on social determinants of health and primary care quality and the impact that practices can have on outcomes and moderate the impact of social determinants of health. So some specific projects we're working on that you might be interested in is, again, NP work environment and its impact on chronic disease quality and outcomes using Medicare data, characteristics of primary care teams that impact chronic disease quality and outcomes. We're also interested in what determines nurse practitioner work environment and their experiences of burnout and job dissatisfaction or job satisfaction, looking at rural, practice independence, all sorts of different things that would determine how good their jobs are, so to speak, or how well they enjoy their jobs. Determinants and outcomes of practice independence. We're very interested in nurse practitioner independent practice, emerging out of a lot of our work around scope of practice regulation, state scope of practice. And then another one that will be controversial is looking at workforce experiences and patient outcomes among care delivered by DNP and MSN prepared nurse practitioners, which many of you on this call, I assume, will know is a very controversial topic within nursing schools. Some things we found, again, these are very high level. These are some of the papers that are in press. Rural NPs, higher levels of independence, they have fewer structural capabilities that facilitate quality care, poor relationships with physicians. We also found that DNP prepared NPs are very, very similar in terms of practice roles, independence, work environment, compared to MSN prepared NPs. They seem to not be used differently than MSN prepared NPs, which may or may not surprise people. To a certain extent, they have more favorable relationships with their physicians, work more leadership, they work fewer clinical hours, they got more leadership roles. And then we also have studies looking at practice independence and burnout, finding that NPs that have more practice independent tend to be more burnout. And then we also looked at independent panel management and found that it has little to do with NP experience and age or degree, and really everything to do with the practice environment that exists within the primary care practices, as well as state scope of practice regulations. So just some of the sort of high-level findings from the papers. So the second core is the nurse practitioner and specialty care. We're very interested in understanding how nurse practitioners are used, particularly in ambulatory specialty practices, so cardiology, pulmonology. As many of you know, nurse practitioners are not certified in subspecialties, but are certified in adult, peds, women's health, behavioral health, and then within a population, so adult, gosh, I'm getting this wrong. But, acute versus primary care. So we're really interested in, what kind of certifications health systems are looking for, kind of experiences to hire people into ambulatory specialty practices. So although that core is broader to encompass acute care NPs as well. So we've looked at NP workforce issues in pediatric ICUs, acute care NP educational programs. We've looked at the impact of scope of practice regulations on acute care NP practice. And the big one is we're collecting data right now, looking at employment and utilization of NPs in ambulatory specialty practices. So I'm actually going to maybe skip a little bit of the key findings, but I'll just sort of gloss over them pretty quickly. Let me see what's probably interesting here. We looked at pediatric NP programs, very few of them, very small cohorts. They're very concentrated in specific areas. And so the point is, as hospitals try to hire acute care pediatrics NPs to work in PICUs, it's very, very hard to find folks that actually specifically came out of acute care pediatric programs. And a lot of the NPs that work in ICUs tend to are family nurse practitioners that then their practice is a little bit misaligned from their education and their certification. We also find that scope of practice regulations have almost no impact on inpatient NP practice, which you might expect, but they're more likely to bill. So actually scope of practice for inpatient NPs has no practice impacts, but has billing impacts. So NPs are more likely to bill if they're in expanded states. And then we actually found that there are pediatric ICUs that employ APPs, advanced practice providers, particularly NPs. The patients tend to be younger and sicker, but they don't have any differences in terms of mortality. So making the argument that safe staffing and APPs included in PICU staffing provide safe care. They tend to care for very sick and frail patients. So the last one I want to mention is the Behavioral Health Services Research Core. That's run by Haley Giermack. She's an assistant professor, relatively new to the institution, very good researcher who is doing some really interesting work on behavioral health care. Particularly, she's interested in patients with serious mental illness, and particularly on their physical health outcomes. Because, as you could imagine, the vast majority of people with serious mental illness don't die from their schizophrenia. They die from heart disease because, if you have a serious mental illness, it's somewhat difficult to care for your condition, and their access to healthcare is challenged. So very interested in how we improve physical healthcare for those with SMI, and then other questions. So you can see through this, we've already submitted 8 grants, primarily through Haley, but then we also have graduate students that are submitting funding proposals. And she has a monthly meeting that, again, is part project meeting. We talk about a lot about papers, lots of feedback for students. So it's very much a working meeting, idea generation, a lot of fun. The questions that interest that group are around how do nurse practitioners care for patients with behavioral health conditions? So we're using Medicare data to really look at, actually that's not true, we're using Optum data, which is a data set at the University of Pittsburgh, which I can talk about if you're interested. A very big, very exclusive, large data set that has health insurance claims and chart extracted data from payers and health systems throughout the country. Looking at what kind of care nurse practitioners deliver to behavioral health patients, also particularly within the context of telemental health, is something that we've been working on. We also have a project that's being run by Jen Seaman, also here at Pitt Nursing, looking at palliative informed ambulatory care for patients with dementia. She's going to be putting in a funding proposal or funding application very soon. We look at postoperative opioid use among patients with SMI, very vulnerable population to addiction. And then determinants of readmissions of individuals with behavioral health conditions. We know that folks that suffer from behavioral health disorders are much more likely to be readmitted for physical health conditions. And how do we help them with their transition to outpatient care to keep them from being readmitted to the hospital? Also interested in psych med changes. That's something that Haley's really been focusing on. Also, generally psych med changes, but also particularly among pregnant women, as they there's oftentimes, as many of us know, women who get pregnant often choose to or must wean off their psych meds. That obviously creates some challenges in the pregnancy period, but especially in the postnatal period. So there's also been some work with the VA. So we've looked at how we have a paper that I think is about to be published, looking at the impact of various models of care delivery in the VA and how it lowers readmission rates among folks with serious mental illness. We also find great hospital level variation readmission rates among patients with SMI. Very long persistent post-operative opioid use among patients with SMI. That has obviously some serious implications for behavioral health and well-being. And then, and then we also look at patients who are particularly vulnerable to being returned to very low-income communities. So we find that it's especially patients with SMI are much more likely to be readmitted if they're discharged back into a low-resource community, and they get readmitted at a very high rate. So how do we help, again, with that transition back to home for patients with SMI? Was there a question? I see that there's a comment. Okay.
Yes, there is. So the question is, do you have any suggestions on how to engage nursing students, whether that's undergrad and graduate students, in health policy?
Yeah, so that's a good question. So we do, I'll show a slide about this later, we do engage a number of students in our course. So if you're thinking specifically at Pitt, I would really encourage them to contact us. Another way, particularly for undergraduates, is within the University of Pittsburgh, is we teach two health policy courses for undergraduates. I'm just wrapping up one called Health Policy and Human Flourishing, which is a deep dive on some of the conceptual foundations of human health, and then the role of the government to promote health and flourishing. But in terms of, it's a little pedestrian, but getting involved in your association, right? Whether that's the American, the ANA, the American Nurses Association, that's really where the advocacy work is done. So also, as we're, particularly graduate students are writing papers, always keeping in mind, what can the state do in order to improve care for the condition I'm interested in? And the other big one is honestly just reading the newspaper and keeping yourself exceptionally well informed. I often find that nurses are very interested in advocacy, but not a great background in how government works, not super engaged with sort of the cultural issues going on. And obviously this isn't definitive, but honestly just reading the newspaper Yeah, and keeping yourself abreast of what's going on socially. But at Pitt, I'd encourage them to contact me, get involved in our research in the cores, and then also to take the classes that we offer, 2 policy classes, 1 required, 1 not. Okay, thank you. So the last thing, well, 2 more things I'll mention. One is the research colloquium. I'd really encourage folks to come. We have anywhere between 12 and 30 participants that come in live. Obviously, the Zoom has helped to get folks engaged from across the university. Those are the 2nd and 4th Tuesdays of the month from 9 to 10. Although, if you're in the nursing school, faculty will receive an announcement. We have 2 very special folks coming at noon. I don't have the dates, unfortunately, but we can make those available. We're bringing in folks, one from the University of Pennsylvania, Matt McHugh, who is now running the Center for Health Outcomes and Policy Research at Penn, which was sort of the original nursing health service and policy research shop in the United States. Originally run by Linda Aiken, now being run by Matt McHugh, and he's going to give an update on sort of the future of nursing health services and policy research. And then Olga Yakasheva, a researcher at University of Michigan, who is probably doing the most sophisticated work on nurse staffing and patient outcomes. So normally, 2nd and 4th Tuesday of the month, although they're done for the semester, they'll re-engage in the fall. We have 2 more that are special times at noon, and they're a Tuesday and Thursday in April and May. I can find you those times when, if you're interested. So you can reach out to me if that interests you. So obviously, you can't take all this in right now, but here's a long list of the colloquium presentations we had this year. So how many do we have? 3, 4, like 12, I think. And the things I do want to highlight is this is a mix of senior faculty, junior faculty, professors and students, folks inside and outside of the nursing school, and folks inside and outside of University of Pittsburgh. We had a friend of mine come from Duquesne to do a presentation on the Constitution, actually. We're trying to do a little bit more on political theory. We had someone present from UCLA, and then someone just today from Ohio State. So we're trying to keep it very broad. And I think they're really interesting topics. I think that there will always be a few that are right in your wheelhouse, and I think all of them are interesting. So I'd really commend this to you if you're interested in this field to really try to make it to our talks. We do send these out via the listserv faculty and students at the University of Pittsburgh, and we also put them on our HUB website, which again can be made available as well. I did just want to point out student participation in the cores. We have 4 graduate students that work with us, 3 PhD students and 1 DNP student, and 3 undergraduates. Although probably more now, we have a number of students that come in and out and do work on projects. These are sort of our 3 really consistent undergraduates through the URMP program. They're invaluable. We're trying to get them as co-authors on papers, so they'll emerge from Pitt with some papers on their CV and really launch them into research if that is something that interests them in the future. So what's on tap for 2021, 2022? Like I said, we've only been funded for about 8 months. It usually run, so I think we were maybe a little bit longer, maybe more like 10 months now. But I think we're just going to continue the work of the cores in the seminar. I think it's gone really well. They've been well attended. We're getting product out, papers and grants. So I think that this structure is working. So we're going to continue that. I didn't mention the pilot projects because they're very self-contained, actually. But we're going to fund 2 to 3 new pilot projects. We put out a request for proposals. So I think we'll be able to fund, again, anywhere between 2 and 4, actually probably 2 and 4 new pilot projects, depending on how much each one of them request. We're going to develop at least 1 new core that I'll be leading that is a little bit different than what we're doing. Again, less focused on the healthcare system, more focused on culture and our social life together and how that impacts health and well-being. I'll talk about that in just a second. We're going to submit 2 major grants and 3 minor grant applications over the course of the year. And then again, just really disseminate the work through our website. I'm really hoping to really build out our website and make it really a place where folks can come and really get a good sense of what we're trying to do. I just wanted to really quickly tap the new highlight the new core that I'm tentatively calling health policy and human flourishing. So this concept of human flourishing, I think, is really helpful thinking about sort of a capacious understanding of human health and well-being that incorporates all aspects of human life, including happiness and life satisfaction, mental and physical health, meaning and purpose, character and virtue, and having close social relationships, sort of the things that we're really motivated to pursue as people for their own sake. The health service and policy research has always been relatively narrowly focused on the healthcare delivery system, and we've realized for a long time, but there's this increasing focus on social determinants of health and the sort of broader context in which people live and the broader understanding of what really drives human well-being. So what we're really trying to do in this core is to investigate ways that this concept of human flourishing, it'll be informed by literature, art, sociology, political theory, et cetera, how might that expand the horizons of the typical health policy discussion? So what does literature have to say about what it means to be human? What does that mean for what it means to be a human person experiencing well-being? And what can we do as a people to foster those sort of conditions to promote human flourishing? So it's ambitious and still in progress. But I think a couple of things that we're going to do is I'll be recording a monthly podcast. I've recorded 3 episodes, and they're in the process of being edited, and they'll be released somewhat soon. I'm doing that in combination with a research institute in the city of Pittsburgh that has an ongoing podcast series that I'm a part of. So we have 2 things that we're kind of working on. One is an investigation of healthcare sharing ministries, which is an approach to health, sort of approach to paying for healthcare that's grounded in the virtue of mutual aid and sharing as opposed to health insurance, which again, I can get into more in depth if you're interested. And then also, how do we measure flourishing in health services and policy research? So I have a paper that I'm developing with some colleagues here and other institutions thinking about the question of measurement. And then we have some other initiatives that we're thinking about. And we're also trying to put together monthly reading groups. So that's something that we're going to be working on starting this summer through next year, if that interests anyone here. And I think that's it. I'm right at 41 minutes. So I've met my first goal. So open
Impressive. Did you time it? You were like, I got 41 minutes. And here we go.
I hit a point in my career where I know how many slides get me to 41 minutes. So.
Well, thank you so much. This is all very fascinating. One of the long-term goals that Dean Dunbar-Jacob is looking forward to in doing is an advocacy center for alumni and students to be able to access if there's legislation or whatever. So this is really fascinating to be able to think about all of that stuff as I potentially start to look at some of those, how to get that up and running.
Sure.
So I do have a few super quick questions.
Mm-hmm.
So as I mentioned earlier, this is our 3rd session of our the HUBS research presentations. I know there's 5 of them.
Yeah.
So for homecoming, we did the sleep and circadian rhythms, and then we did genomics of patient outcomes in January, I believe. Yeah. So within the 5 hubs, do they work together at all? Is there any room for collaboration or sharing of resources, or how does that work?
Yeah, so far, I can't speak to the other ones, but so far we've been relatively self-contained. Now, I do think that's a good goal, is to have much more communication between them. Now, I will say that there is an oncology core. Am I remembering this correctly?
Yes, I believe so. Yeah.
So we're Kathy Bender. So we've actually, I forgot about this. We have a joint project where we're using this Optum data set that I mentioned before to begin collecting some preliminary data for a larger grant application that does some oncology health services research. So actually that is one area of overlap. I can certainly see some good overlap with the technology core, and I can see ways that we could work together, and what's interesting, the genomics one, as part of the policy and human flourishing, we're really thinking about ethics, policy ethics, and there's some real interesting, important work that needs to be done in genomics ethics that has some real implications for government and public policy. So, so I would say a little bit of actual engagement with the oncology core, but I think that's a good goal to integrate these cores a little bit more.
Yeah, absolutely. Yeah. There's, I mean, the School of Nursing has amazing researchers across the board. So I think room for collaboration is great for everyone. So earlier in your presentation, you talked about the potential for like funding opportunities and what that might mean for your hubs. You talked about like the fun opportunities that would lead to based off the funding. Can you talk a little bit about what would be the long-term goals for the funding opportunities?
Yeah, so I mean, I can tell you what the long-term goals are for our dean, or our major R01s through NIH, and that's our goal too. So that really, I mean, ultimately as a nursing school, that is our goal in terms of funding is NIH R01. Now, I would like to be creative and find other funding mechanisms, but really when it comes down to it for tenure considerations and for our national rankings, that's really what it is. Yeah. And that really, I mean, that's an overt goal is everything that we fund through RFPs within the core need to demonstrate that this could plausibly lead to an R01 through NIH.
Yeah. So for the funding, like what would you want to be able to do besides the R01 fund? Like what would you want to be able to do with the fundraising?
Oh, you mean if we got like non-grant funding? Like
or just like grant funding, if there's like a dream thing that you would like to do?
If there's anyone on the call that has a lot of money in his name, like being
I like that pitch. That's nice.
we need some research. So we're essentially at a point where we have a lot of grant money. We have a lot of really eager researchers, but we haven't quite been able to cobble enough together to get a full-time programmer, someone that does big data and can go into very, very complex data sets and pull out research data. That is our number one biggest need. And again, we're like so close. We need to get someone like that. You need between like $80,000 and $120,000. We just don't quite have enough. And I think that's really the big one. And just some administrative resources, I think would be exceedingly helpful. I would like to actually be the location for the next Bozeman meeting, which is bringing together nursing, health services researchers from other disciplines to really talk about the future of our field. Again, that was hosted 2 years ago in Bozeman. And it was funded basically by Montana State. I would like to be a place that's thought of in that way as, where we bring people together to have these big conversations. So that'd be great. If we could have those, especially the programmers, if we could have those, I feel like the sky would be the limit, and it would just drastically increase our ability to do really interesting work.
Yeah, absolutely. That sounds great. So very early on in your presentation, you talked about the discrepancies between healthcare availability and distribution. Have you found any that diversity plays any aspect of that? Do you focus at all on that within the hubs?
Yeah, so it depends on what you mean by diversity, I suppose. I mean, all of our research involves diverse populations. I mean, we have neurodiversity in terms of the questions around SMI. Now, the projects that I've funded through the National Institutes of Minority Health and Disparities is expressly about healthcare disparities, particularly between white and non-white Medicare beneficiaries. So, I mean, I do sort of have a heavy focus on healthcare disparities in my work. I'm thinking about how nurse practitioners particularly are well positioned to help reduce disparities because they often disproportionately care for minority patients, particularly low-income minority patients. They tend to be in communities and also in rural communities as well. So we also have that focus too. Again, it all depends what you mean by diversity. We have a pretty heavy rural focus as well, where the healthcare system is notoriously under there's workforce shortages, and their outcomes are pretty weak. So yeah, I do think we have diversity focus, but not self-consciously. I think that's just kind of the word.
Yeah, it's just a natural kind of lead in. Yeah, of course. So I think the last couple of questions that I have revolve around everyone's favorite topic is COVID. You talked a little bit about burnout and how particularly like nurse practitioners in the independent fields are more likely to have burnout. And I know that a lot of people in the healthcare field right now are experiencing those feelings as well. Are you planning on having a COVID research topic as part of that kind of section, or how does that?
Yeah, so, well, all right. Part of me just wants to avoid everything COVID because I'm burned out.
That's completely fair.
I'm burned out on COVID. And in fact, the friend of mine and I who run this podcast, we're like challenging each other. Can you do an entire episode and never mention COVID? It's really, really hard. But with that being said, Haley Garamack and I did put an op-ed piece in the Post-Gazette a few months ago. Many states expanded scope of practice for nurse practitioners. So in the state of Pennsylvania, for example, you have to work in collaboration with a physician in order to be a nurse practitioner. Many states have similar and even more stringent laws, whereas other states, nurse practitioners are totally independent and can function under their own license, independent of any physician collaboration or oversight. States relaxed those during COVID in order to get more people, to increase access to care. And so the real question is, what's going to happen once COVID is over, if it ever ends? Will those laws just go back to where they were? Because they're executive orders, they expire, or will those state legislatures realize that this was a good thing and put laws in place that expand the scope of practice? So that's probably the closest that we get. Haley Garamack, Dr. Garamack, also is very interested in telemental health, and that has, I would say, in terms of the healthcare system, that's probably, outside of COVID itself, that's probably the biggest. I'll just say this: I'm not sure I totally necessarily agree with this, but I think I do. That's probably the biggest change that's going to result from COVID, is how much you realize you're going to go to the doctor in your living room.
Yeah, all those telehealth medicines and not leaving your house, just doing it over the phone or video over Zoom. I think that makes it a little bit easier and safety for the doctors and nurses, but also like other patients as well. Like you're not intermingling with all of those people. What about like the vaccine rollout? I know that like all of the states are so different, and the government has also been like hesitant, and not hesitant, but there's been some changes. And is that going to be a focus at all? So
that's so much in the purview of like public health, which is a little bit different than what we do. Although it's it's interesting that all of the vaccine is being delivered through the healthcare system, which is not necessarily how it has to be. Yeah, I mean, you could do this and not through like UPM. In Pennsylvania specifically, all the vaccine was given to major health systems, and then physician offices and pharmacies. It doesn't necessarily have to be that way. So we don't do much on vaccine policy, although I guess we could, but we don't. No.
Yeah. I mean, just COVID is just a really fun topic. And everyone, I mean, as you said, you can't get through a conversation without talking about it. So, okay, well, great. Thank you so much, Dr. Martsolf, for sharing all the wonderful research happening within this hub. It's very interesting, especially all of the different grant funding things and all of the projects that you're working on. It's all really wonderful. And thank you all for our wonderful participants and registrants for attending this virtual event. We're planning on continuing virtual events as we still live in this virtual world. So keep an eye out for emails. And like I said earlier, we will be sending out the evaluation tool for the continuing education contact hours and credits. So make sure you complete that to gain the contact hours. So thank you all once again, and have a wonderful rest of your Tuesday. It is Tuesday. I get confused about what days it are now in this world. But thank you all so much, and hail to Pitt.
Yeah, thank you so much. Take care.
Bye.